minimize this. Where is it? This gets if I can't, so I can't read some of my slides.
The little minimize.
If I hit this one,
Yeah.
but then how do I get it back?
Oh, open it back up. Yeah.
Then I got to open it back up like that. Okay. All right. So I minimize so I can get it back. Okay.
We are now live. Hello, web shadowers. Thank you all for attending our session this afternoon. Today, we have the pleasure of hosting Dr. Wood again, who will be teaching us about reproductive endocrinology and infertility. As always, please remember that the Google form will be posted in the chat box at the end of the live stream, and it will also be in the description. With that being said, Dr. Wood, you may start whenever you're ready.
Okay, great. Hi, everybody. This is the second time I'm doing this because it was really fun the first time, just having being able to review a case of something that a lot of people don't get a lot of exposure to. So I just want to review essentially me. And so what I do, so I'm an infertility physician, okay, which means I am an OBGYN trained, and then I did a fellowship in reproductive endocrinology and infertility. I love to exercise. I've run 8 marathons, and I'm a mom of 2 daughters. So my education consists of a very kind of not super traditional way to, go to medical school, even though my education was continuous throughout. So I went to undergrad at University of Pennsylvania. I graduated in 1988, and my degree is very interesting. It's in international relations, and I had a minor in Spanish. So every single pre-med class that I took, interestingly, was all of my electives, essentially, because I needed my main credits for my major. So I wasn't really sure whether I wanted to be a doctor. And my father at the time says, oh, we'll just apply. And so I wasn't really, again, this wasn't a lifelong dream, but I figured I took the pre-med prerequisites. I took the MCAT. I just applied. So I only applied actually to one medical school because it was 10 minutes away from my house. And miraculously, I got in. So he wasn't even sure after I got in whether I wanted to go. My father encouraged me, oh, just go, just get it. What else do you have to do? Just get a degree. You don't actually have to practice medicine. So my first year in medical school was just a lot of the basic sciences, really didn't like it very much. The second year, it was clinical. I started to like it a lot more. And then once I got, placed in the hospitals the third year, I said, wow, this is really fun. I could do this for the rest of my life. Back in the day, after you graduated medical school, we all were required to do a rotating internship. So you didn't go right into residency, you did a rotating internship. So the rotating internship, you rotated through medicine and pediatrics and surgery and all different specialties for 12 months. And then you kind of decided on what type of residency you wanted now. Now you guys just go in right into residencies. And so I had decided when I was in as a student that OB was really, really interesting, even though, again, my father thought my life would be better as a dermatologist or a ophthalmologist. I did 3 dermatology rotations, and I could not watch another wart get burned off. So that was definitely crossed off the list. And I did 2 ophthalmology rotations, and if I saw another eyeball, I was going to go crazy. So this was not very fun. However, when I was in the 3rd year of my medical school, I had an OB rotation, and you had to do night call. And the very first night call that I was on, the first year resident, patient came in labor, and and he goes, hey, do you want to come in and deliver a baby? And so walked into the room, and the ladies actually started to push, and we were doing a bed delivery, so she wasn't up in the stirrups or anything. And he put my hands on the baby, and he walked me through it. I delivered the baby. She had a little bit of a tear. He handed me the needle driver, and I sewed up the tear on her vagina. And I'm like, that was such a rush. I'm like, I want to be an OBGYN. And delivering babies was just so ridiculously fun. So I applied to OB residency, and we got in at the same institution where I went to medical school. I had a wonderful, wonderful 4-year program in OB. But the problem was, at the time, OBGYNs, and it still is a very grueling profession, but you can make it manageable. At the time, again, very, very, very intense. My husband was also an OBGYN, and we looked at each other and we said, hey, look, one of us needs to do a fellowship. And at the time, we had 3 fellowships at OB. So you have maternal fetal medicine, which in Philadelphia at the time, they were delivering babies. So this really the night call and everything, having a family was going to be pretty difficult. if we're both delivering babies. And maternal fetal medicine is a great subspecialty, doing high risk pregnancy and lots of ultrasounds and things like that of babies, but it was not going to be conducive to a normal lifestyle. So the other subspecialty was gynecological oncology. So GYN-onc, the surgery is incredible, absolutely incredible. We were just getting better with the laparoscope and doing a robotic. We hadn't done robotic stuff yet, but the laparoscopy was really just getting ramping up, and everyone was learning how to do it. And the visualization of the anatomy was just amazing. The problem is gynecological oncology is kind of sad, like people die. So, I mean, you do save people, but it's still, you take care of people that are obviously very, very sick, and you're trying to save them of their cancer. So that was kind of depressing. And so we decided that wasn't great. So I said to my husband, I said, look, you need to be the endocrinologist. I said, this is a great specialty, great hours. You need to be the endocrinologist, and I'll be the general OB-GYN. I love delivering babies. This is great. He goes and he does his rotation as an REI. And he's like, no way. He's like, I hate this. I'm like, no, you're not allowed to hate this. You can't hate this. Like, you have to be the endocrinologist. I'm going to deliver babies. So I hadn't done my rotation yet. And I went in and I did my rotation, and I'm just like, this is great. Manipulating the menstrual cycle. I'm like, ultrasound's getting people pregnant. Everybody's healthy. This is almost as fun as delivering babies. So I had applied for a fellowship, and I got the fellowship spot at Pennsylvania Hospital. Then the hospital system got bought by University of Pennsylvania. They kicked us out, and I finished up my fellowship at Thomas Jefferson in Philadelphia. So, but it was literally, this is a wonderful job. I mean, there's only a couple things that are not the best about my job, but making families and making babies, I can't say enough about how much fun it is. So I came out of fellowship, and I had an academic position in Philadelphia, and in the former Hahnemann University, which currently no longer exists. And I worked there for a year in academics, and it just wasn't fast paced enough for me. And so in October of 2000, I joined this practice in Florida. And so right now, we're one of the largest practices in South Florida. We've got 6 offices. We have 12 physicians, and I'm in the Cooper City office, and that's what I'm doing. So what I'm going to present to you guys today is just a case of a couple who came in to see me. I think they came in September, and I'm going to just kind of walk you through kind of their journey, because it's kind of one that elicits a lot of different points, and it's kind of fun. It's kind of fun. I love the ending. So let's move on to our case. Okay, so this is kind of my day. Like, this is what I do. I'm like a detective all day. So people come in as a couple, and my job is to figure out why they're not getting pregnant, because that's why they're showing up here. So this is W, this is T, and this is going to be like their fertility journey. So this is their first visit. So she is a 28-year-old Jamaican female, G1P0, which means that she's been pregnant once, and she's had 1 miscarriage, which ended in a loss. She's been trying to conceive with her partner for 2 years, but they've been together for 9. Okay, so obviously you're thinking, she's pretty darn young. And she states that she was diagnosed with something called polycystic ovary syndrome when she was in Jamaica. So what do I think when she comes in? What kind of thoughts are going through my head? Okay. Well, first I'm thinking she's only 28. So does she meet the criteria for the definition of infertility? So yeah, she's been trying for more than a year. So she definitely check that off. She definitely should be here. She's in the right place. She's with the right type of doctor to help her. Then I'm thinking, she's conceived once before. So I got to keep this in mind. I'm not sure how significant it is, like why somebody in their 20s would have a miscarriage. That's always like, it makes you scratch your head and like, I mean, it happens. Miscarriages are actually pretty common, but not as common in women in their 20s. So I'm keeping this in the back of my mind. And then I'm also keeping in the back of my mind, someone told her she has this PCOS, this polycystic ovaries. So I'm going to kind of continue my search. So let's talk a little bit about PCOS. What is it? Okay. So PCOS is a condition that affects about 1 in 10 women of childbearing age, and it can mess up your fertility. So definitely might be why this young lady is not getting pregnant. However, the interesting thing is that no 2 women have the same symptoms. Okay. Which makes it very challenging because it could present as many other conditions can present in a similar way. So women who are trying to conceive with PCOS, they're often really good candidates for fertility treatments. And sometimes the PCOS diagnosis is challenging. So a patient comes in and say they have irregular cycles. And a lot of times the knee-jerk thought is that they have irregular cycles because they have PCOS. Sometimes actually it can actually be early menopause. So you gotta be careful, just kind of knee jerking that everybody has PCOS. So what's the criteria for PCOS? Okay, so in 2003, the Rotterdam criteria for the diagnosis was established, and then it was reaffirmed that this is the best way to try to diagnose people and say they have this condition or they don't. And so they reaffirmed it in 2013. So oligo or anovulation. So you have to determine the patient is not ovulating, okay, because a woman should ovulate every month, okay, or she's ovulating sporadically, which is the oligo ovulation, which means she ovulated in January and then she didn't get a period and maybe she ovulated again in April, but not ovulating consistently every month. So they have to check, that has the one thing. Then they have to have clinical or biochemical symptoms of hyperandrogenism, which means extra hair. So that's this down here. This is, you have a little bit of chin hair. You can get chin hair, chest hair, balding up here, and that can all be signs of extra male hormone, okay, which is what's meant by hyperandrogenism. The picture up top here, this is the kind of a big chubby ovary. So polycystic ovary patients, like, a normal ovary is kind of looks like that, but a polycystic ovary patient has like a big chunky ovary. I mean, it's just kind of like a big, it's when you look at it, when you do surgery, that's what this picture is. This top picture, this is the fallopian tubes, this is the fimbria. And then this is this white thing here, that's an ovary, but this is a big chubby ovary. And this yellow stuff here, that's just the fat inside the belly. So you have to have irregular periods or just not ovulating or no periods at all, which mean, anovulation, not ovulating at all. Either have to have clinical hyperandrogenism, okay, or the criteria for polycystic ovaries on ultrasound, which is over 12 little follicles. I'll show that in the next slide. And then you have to exclude other things that will look like that, which is congenital adrenal hyperplasia, which is CAH. Obviously, you have to exclude androgen secreting tumors because that's where the extra hair and the testosterone could come from, and Cushing syndrome. The CAH and the androgen secreting tumors and the Cushing syndrome, very, very rare, very, very rare. But you always have to keep it in the back of your mind. I mean, I think I find one every 5 years or something. But these are diagnoses that you certainly don't want to miss. Because that would be, that could be devastating as far as what the treatment options are. So in order to say you have PCOS, you have to have two of the three. So if somebody has ultrasound evidence of PCOS and they're not ovulating, but they're not hairy, they make the criteria. So just two out of those three criteria, and you could say, yes, her picture is consistent with polycystic ovaries. So this is what I was talking about the little follicles. So normal ovulation. Okay, so you got a little follicle here. This is the beginning of your cycles. This is day 1 when you're bleeding. As you start to go through your menstrual cycle, the little follicle grows and it grows and it grows. And so what's being produced inside this follicle is estrogen or estradiol. And the estradiol is produced in a cell called a granulosa cell. The granulosa cells continue to produce estrogen until it peaks at around 200 picograms of estradiol. Then it tells your body to send out this LH pulse, okay? The LH pulse makes the egg pop. Then what happens is the estradiol levels, okay, right here, they drop. And the progesterone level right here, this green line, this is progesterone, it starts to rise. And that is produced by what we call a corpus luteal cyst. And that's this yellow thing. If the cyst collapses, it fills with blood and it starts to make progesterone. So this is what happens normally. In a polycystic patient, okay, all they just have is just little follicles, like just all the little follicles. Nobody ever grows big, nobody ever pops. So when you look on ultrasound, there's just tons of little follicles just hanging out. And if you're not ovulating, it makes it kind of hard to get pregnant. So this is the ultrasound appearance, okay, that we see. So you have to have at least one ovary with all these little black things, okay? These are all little teeny weeny immature eggs, okay? And then you have to do the ultrasound between day 2 and day 5 of the menstrual cycle. And all the little follicles have to be tiny. They have to be between 2 and 9 millimeters in size. And then, as I said, these polycystic ovary patients, again, they also have chunky ovaries. So the ovarian volume needs to be greater than 10 millimeters in the absence of a cyst or a dominant follicle greater than 10 millimeters. So that's what I was talking about. They're big, like just this bigger than average type of ovary. So this is what we would see on ultrasound. So polycystic ovary has all these little black follicles, and these are all less than 10. And this is a normal ovary. So you have a little one here and one size here, and you have kind of different ones, but it's not super filled with gobs and gobs of those little black circles. So just a little more stuff on PCOS. So women with PCOS, they also can experience other concomitant health conditions that when you're taking care of these patients, you really have to be aware of. So metabolic syndrome. Metabolic syndrome is something that goes hand in hand with PCOS, and it has to do with insulin resistance, high cholesterol, and hypertension. So it's just, it's a kind of a global diagnosis of poor health, and all of these things can lead to chronic medical conditions. Usually let's say we don't see them in young women, but every once in a while I do. The PCOS, because of the cholesterol problems, the high blood pressure problems, and the insulin resistant problems, can lead to heart disease, diabetes, as well as potentially endometrial cancer. So the reason for the endometrial cancer is because the ovary is not producing progesterone if you don't ovulate. So the entire menstrual cycle is a balance between estrogen and progesterone, okay? But if your uterus day in and day out only sees estrogen, okay, you're a setup to cause changes inside the uterus that could lead to cancer. The youngest patient I've had with cancer with PCOS was 28. I had another one who's 34. And then I had a full-blown adenocarcinoma in a polycystic patient, which obviously people trying to get pregnant at age 40. So this can happen to young people, which is why it's important if a PCOS patient is not trying to get pregnant, that she be either taking progesterone every 3 months, progesterone monthly, or just the easiest way to treat this in a patient who's not trying to conceive is with the birth control pill, because you give her back the hormones that her ovary is making, protecting her uterus from further just estrogen. If some people don't ovulate, how do you know what day of the cycle they're on? Exactly. That's the question. So the way I do it, okay, we have ultrasound in our office. So we can draw blood for estrogen and progesterone, and we can do ultrasound to look at the ovaries and see if the patient is ovulating or not. And that's the challenge with the polycystic ovary patient. They don't know if they're ovulating or not. So the first day of bleeding is always considered day 1. Okay. Most women will ovulate between day 12 and day 14 or 15 of the cycle. Polycystic patients might ovulate on day 30. They might ovulate on day 60. And that makes it very difficult to get pregnant, which is where fertility doctors come in. Since the symptoms vary a lot between women, often women are misdiagnosed for other conditions. Yes, that's true as well. That's true as well. I mean, I think mainly for the OBGYN, OBGYNs mainly, they see PCOS so often that most of them are pretty well versed in it. But I've seen a lot of patients end up with me that they actually weren't diagnosed with polycystic ovaries. But you need to meet 2 out of those 3 criteria in order to say, yes, that's what you have. With this young lady that we're doing the case on, she meets criteria, but for different, 2 out of the 3 reasons. But I think the actual polycystic ovary diagnosis from her OBGYN in Jamaica actually was not correct. So there's no cure for PCOS, but many of the symptoms can be treated or managed, again, with lifestyle changes and medication. So when I talk to a patient with PCOS, they come in, some of them will just see me for PCOS management, and some patients will see me, most of them see me for fertility. We'll say, hey, do you want to get pregnant or do you want to get pregnant? And the pathways completely diverge and on one side of the spectrum and the other. So in our case, W, she reports irregular menses with long, heavy bleeding and maybe only 5 or 6 menses a year. Okay, so she meets criteria there for PCOS. So I'm keeping this in my head. So just maybe she really does have this diagnosis, and she actually tried a fertility medicine called Clomid, okay, for one time in Jamaica when she was there. So what's Clomid? Okay, so I did a post on Instagram on oral fertility medications and which ones are better. I have my posts, the pros and the cons of this, because anybody who's done any fertility treatment or is very familiar with these medications. But what is Clomid? So when she tells me she's used Clomid, I know what it is, okay, but you guys probably don't know what it is. So what Clomid is, it's a drug, okay? It's an ovulatory stimulating drug. It's used to help women ovulate, and it's one of the most common fertility drugs. Very effective. gets people to ovulate 80% of the time. If a woman has irregular or anovulatory cycles, so again, menstruating and not ovulating, Clomid usually is tried. And it's often used in treating polycystic ovary patient-related fertility. There are other drugs that we use for fertility. But Clomid, again, it's one that most people are familiar with. So the way it works, okay, is it works at the level of the brain. So it actually works like an anti-estrogen. It triggers your brain, the pituitary gland, to secrete an increased amount of FSH, or follicle stimulating hormone. So what happens is you've got all these little follicles in the ovary. Okay, you saw in that picture before, it's like, you've got more than 10 little follicles. Well, it's kind of like trying to talk to a crowd without a microphone. Okay, so the pituitary gland sends out pulse, pulse, pulse. And it's just like talking. Well, because there's so much noise going on in the ovary, it's like maybe the guy in the front row will pay attention every once in a while, but pretty much all those little follicles just talking to each other, and no one's paying attention to what the pituitary gland is saying. So Clomid kind of gives your pituitary gland a microphone so that it can start shouting at the ovary, and maybe you'll get one of those little teeny weeny follicles to grow. And so this action is going to stimulate, hopefully, the growth of an ovarian follicle and thus initiate ovulation. During a normal menstrual cycle, then hopefully only one egg is stimulated. So the neat thing about Clomid is that there is an incidence of twins, it's 5 to 8%, but usually only one egg gets stimulated. So once one starts to roll, the rest of the guys just kind of, they just go back to quiescence. They go back to just sitting around in the ovary. So the other medication I was talking about is Letrozole. Okay, so we've got 2 fertility pills, and that was in my post. I kind of compared the 2. So Letrozole is another fertility pill. It's a drug class called an aromatase inhibitor, and mainly it's an anti-breast cancer drug. So Clomid is approved for fertility. It's FDA approved to use for fertility, but it is, but Letrozole is not. Letrozole is not FDA approved. We use it off label. It's usually used for 2 to 5 years to block estrogen for breast cancer patients. But the enzyme aromatase is inhibited by the letrozole medication, and estrogen is also suppressed. So it works pretty much the same way. It works at the level of the pituitary gland to get the pituitary gland to send out more FSH. A little bit different mechanism of action than the Clomid, but it still results in an increased output of the FSH. Now, the study in 2014 showed that for PCOS patients, okay, Letrozole has a higher live birth rate and a better ovulation rate in patients who have this problem. So it's pretty much our drug of choice now. The American College of OBGYN came out with recommendations in 2016 that Letrozole is the first choice. But a lot of times, unless the OBGYNs, regular I've been doing a lot of, or number one, are interested in fertility, have gone to a conference and listened to a lecture on fertility. If you trained anywhere before pretty much 2016, you were trained that if your patient comes in with polycystic ovaries, to give them Clomid. So a lot of the newer docs that are coming out, young, they're using Letrozole, and pretty much all the docs that graduated 15 to 20 years ago are mostly still using Clomid, just because you have a tendency to do how you were trained to do something. And unless, again, you've educated yourself on the newer stuff. So that's why, this patient had seen, she'd probably Clomid back in Jamaica, because again, that's what they were familiar with using. But Letrozole is the superior drug for this condition. So what we're going to go through is just a little bit more of the patient's history. All right. So she reports an allergy to penicillin. She's taking Metformin, which is a diabetes drug, 1,000 milligrams twice a day. She's taking norethindrone, which is a synthetic progestin, to try, because she said, remember, she had heavy bleeding when she initially presented that her periods, like when they come, they're just like, she's like a flood. And so the progestin is progesterone, basically, but it's synthetic progestin. So it's like glue, and I call it uterine glue. It like glues the lining together. So if somebody comes in and they're bleeding heavy, we give them this pill, agestin, and literally within 3 days, dries everything up, just glues everything together. It works so well in 90% of patients. So she's also interestingly taking pravastatin. So pravastatin is a anti-cholesterol medicine. Not something I would really recommend be given 28-year-old girls. So that's something that I advised her, since it does cause birth defects. It's category X. I advised her she really needs to stop taking that. So in general, I rarely see reproductive age women on statins because of the incidence of birth defects. So it's always something that you have to, I mean, I will see women over the age of 45 or 50 on them, but in general, it's not a good thing to prescribe to your patient who's trying to get pregnant. And then again, she's taking Covida, which is an iron, and that's because she's anemic, because she's having so much heavy menstrual bleeding with her sporadic periods. She's also taking a prenatal vitamin. And I prefer patients take a prenatal vitamin with methylated folate in it because it's the most absorbable form of folic acid. They make this over the counter now, but if anybody has a mutation in their body that is preventing folic acid to be broke down into its absorbable form, which is methylated folate, just take the methylated folate right off the bat. You're going to be absorbing everything that you're taking, and it's going to, because folate, hopefully everyone's aware of this, but folate deficiency can cause neural tube defects like anencephaly, spina bifida. It's even been linked with heart defects and cleft palate. So methylated folate is definitely what should be anyone's prenatal vitamin when trying to conceive. And this patient, she's also taking fish oil. So why the heck is she on metformin? Okay. So that's like, it's kind of an interesting drug, but we use it a lot. So it's a great drug for patients with polycystic ovaries. So it's really commonly prescribed for polycystic ovary patients. It was originally developed and prescribed and typically is used for type 2 diabetes. It's one of the oldest and most studied drugs available in the United States. It goes by the glucophage, glucophage XR, glucomet, fortamet, riomet, but it can help relieve the insulin resistance in women with polycystic ovaries. And it works by improving insulin sensitivity, which in turn decreases insulin resistance and glucose production in your body. So the way insulin and polycystic ovaries work, think about insulin as like a little soldier. Okay. And it's like you have an army surrounding your ovary, and their brain is trying to talk to your ovary to get one of the little follicles to like let it out of the castle. But the guards are all around the ovary. And so if you lower the insulin levels, and the insulin is the soldier, you lower the insulin levels, okay, it kind of thins out the amount of guards around the ovary, and it helps the ovary respond to those FSH pulses that the brain is sending out. So it really works in tandem with fertility medicine in polycystic ovary patients. It also helps decrease long-term sequelae of PCOS, which is that metabolic syndrome, that heart disease, that high blood pressure. So if a patient doesn't want to get pregnant and we put them on birth control pills, a lot of times for PCOS patients with insulin resistance, I will also add metformin to prevent their long-term health risks. So again, key feature, insulin resistance is both lean as well as obese PCOS, because you don't have to be fat to have PCOS. Is metformin also off-label for PCOS? Yes, it is. Yeah. Mm-hmm. Yes, it is. Absolutely. It's a diabetes drug, but we've been using it for, oh my God, I've been using it for 20 years now. But yes, also off-label. So this insulin resistance occurs in 70 to 95% of people with obese PCOS, because that's kind of what, you come in, you're overweight, you have your irregular periods, you got a little bit of hair in your chin. It's like knee-jerk diagnosis PCOS. That's why you have to make sure you're thinking CAH and Cushing's and things like that. But most of the time it is PCOS. And high insulin levels even occurs in patients with lean PCOS, which, they're skinny, but they're having ovulatory problems as well. So it's pretty common. Sometimes patients can't tolerate the metformin though, because it does have GI side effects. And I always use an XR, an extended release form of the medication to help with that. So high insulin level is just not a symptom of PCOS. It's a major driver of the condition. And this high insulin levels, I said, like little soldiers, think about it. They can impair ovulation and cause the ovaries to make also excessive testosterone. So that's the excessive testosterone, which is the hyperandrogenism. So all of this is like a syndrome that you have to kind of be aware of all the different parts of it in order to help treat the patient. So let's keep going through her history. So she, her past medical history, that's PMH, obviously PCOS that she's been diagnosed with in Jamaica. She's hyperlipidemia. We saw that because she's taking the statin, type 2 diabetes. So that's why they have her on the metformin, but it also goes hand in hand with the PCOS. And she reported to me the day she came in, she's starting a diet with a new health insurance. So hopefully that'll help her with her diabetes. Most diabetes really type 2 diabetes doesn't need to be managed with medicine. It can actually be managed very well with diet. She also reports a little anxiety. Her past surgical history, she's never had surgery. She doesn't drink or smoke. That's her social history. In her family, again, very similar things. She has diabetes. And her sister has hypertension. Her OBGYN is in Hallandale. And she had pap smear 2 weeks ago that was normal, had a little bit of BV, a little bit of vaginal infection, which isn't really going to affect fertility. And then she reports her period being September 26, long and heavy, very irregular. Her profession, she's a student and an English teacher, an English tutor. All right, so let's talk about her hubby, T. All right, so he's only 27. He had the miscarriage with her. His history is pretty boring. No meds, no medical history, no surgeries. He doesn't drink or smoke. There's a little diabetes in his family, and he works for Xfinity as a cable tech. So after I take their history in the office, now we're going to go into the exam room and we're going to do an examination. And on our physical exam, what we're looking for in PCOS is, again, as we've talked about, signs of hyperandrogenism. Okay, so we're going to be looking to see if she has chin hair, see if she has any, like, losing her hair here, any chest hair. And we're going to also be looking for presence of insulin resistance and the presence of unopposed estrogen, which would mean if we do an ultrasound, we're going to be looking at kind of the lining of the uterus. So most of the time, patients with PCOS, they are obese. It's 70. There's the majority of them, but there is lean PCOS. So this young lady, she is obese. She's 267 pounds and she's only 5'2". So she's a bit overweight. But it's what we see. Patients with PCOS, sometimes they have an elevated blood pressure. That's pretty common. Our patient, she does not, thank God, have an elevated blood pressure at age 28. And her blood pressure was 129/80. And then on their skin, you're looking for, basically, you can look for hyperpigmentation. So you'll see these brown patches on the back of the neck. You can see them in the axilla. You can see them underneath the breast. We're looking for excessive body hair, male distribution patterns. Acne is also common because of the high testosterone. Our patient, just when I examined her, she just had some dark patches on her inner thighs. Now, PCOS patients also have kind of a trunk, like an abdominal obesity, which she had as well. What the brown patches that you'll see sometimes on the back of the neck, they are called acanthosis nigrans, and that's almost indicative of high insulin levels. Like if you see that, you know their insulin levels are high right away. Uh-oh. Oh no, what happened there? That's not good. Okay, let's, where we go? Okay, all right. So when I do an exam in our office, every single patient that comes in, this is not similar to the GYN office, it's just for fertility specialists. I always do an ultrasound, okay? So I do her ultrasound, and these are her actual pictures. This is her lining. It's pretty thin, so that's good. Like all the thickness has gone out of it, because sometimes their linings can be super duper duper thick on ultrasound. This is a picture of her left ovary. So it doesn't really look PCO. Like it's not, this doesn't look like those pictures. I mean, so she has, this one may be able to count 10 or more follicles, but it's not super duper PCO. But she does have kind of does have a little bit of excessive hair, and she definitely has the hyperandrogenism part of PCOS on her examination, and she has the irregularity in her cycle. So she kind of, she does meet the Rotterdam criteria for the diagnosis. So I'm diagnosing her basically with PCOS, which she's been told she had before. I want to make sure she doesn't have any growths in her uterus because of her dysfunctional uterine bleeding. She has the non-insulin dependent diabetes. She has the elevated cholesterol, and I told her she needs to stop the statin, and she's already going to work on that for diet. So what am I going to do? What am I ordering? Okay, because I got to figure out how to get these people pregnant. That's my job. So I'm going to order some preconception labs to include checking her thyroid, checking her prolactin levels. I'm going to look and see actually how high her cholesterol is. I'm going to do genetic testing on her. I'm going to screen some of her vitamins. I'm going to do vitamin D. I'm going to do B12. I'm going to do a ferritin level. I'm going to do an iron. I'm going to do a CBC to check for anemia, because she is taking the iron, and make sure she's not too anemic, because I can't get an anemic patient pregnant, because they're going to feel crappy in pregnancy, because your blood count already drops when you're pregnant. So by the dilutional effect of pregnancy. So I need to make sure that she's going to be healthy enough to be pregnant. I'm going to order an HSG, and that's going to be a test to check her fallopian tubes. I'm going to order a water ultrasound, and that's going to check for polyps inside her uterus. I'm going to order a semen analysis on her husband. Okay, make sure he's got sperm. And I'm going to check STDs on the both of them. I check STDs on the male. I check Hep B, C, syphilis, HIV, it's Hep B, C, syphilis, and HIV. And then I'm going to talk to her about stopping the progestin that she's taking, and then potentially starting a fertility medicine to see if we can get her ovaries to ovulate. So the significant things that came back in her preconception blood is that she has an anti-Mullerian hormone, which is her pool of eggs, not real consistent with PCO, and that's what her ovaries look like. But she still kind of meets criteria because she has the slightly excess the hyperandrogen appearance, and she has the irregular cycles. But the PCO patients with this AMH level, usually this level is like super high, like it's like 10 or 11. But hers is good, the amount of eggs she has, but it's not like excessively good like we see in some PCOers. Her blood type's A positive, her hemoglobin's 11.4, so a little bit anemic, but not awful. Cholesterol is actually pretty good, so hopefully she can stop that cholesterol medicine and not have any bad sequelae, even though her LDLs are a little bit high. Vitamin D level's a little bit low. We like it 40 to 50, so we're going to recommend some vitamin D supplements. And this is her expanded carrier screening. We check all of our patients for 283 genetic diseases, things like sickle cell, cystic fibrosis, spinal muscular atrophy, because we have the unique ability as fertility specialists to make sure that they don't carry, each person in the couple doesn't carry a gene, like say, if they both carried sickle cell, they'd have a 1 in 4 chance of their baby being sick. So we want to make sure that before we help them have a baby, they're not going to be at risk for having a baby with a problem. Okay. And then I ordered a sperm test on him. So this guy has some killer sperm. I'm like, he's not the problem. So his total count right here is 200 million, which is just obscene. He has a total motility of 65%. So what we look for in sperm is 3 things. We look for how many you have, how fast they're moving, and what they look like. And he is perfect as far as normal forms. Normal forms means a normal head, neck, and tail of sperm. And so again, here's a kind of the sperm here. So they need to have a normal head, neck, and tail. And 96% of your sperm come out looking funny heads, funny tails, 2 heads, 2 tails. And so it's normal to have lots of abnormal sperm, but this guy is normal. He is 4%. So it's not likely that male factor is an issue with this couple. It definitely sounds like it is a female issue. So we ordered an X-ray of her tube. So that's the picture of her X-ray. This is her uterus right here. Okay, it's a little flipped this way. This is a little balloon that we have to hold the dye in. And this is her fallopian tube, this little line here. Okay, on the right side, this black is the dye coming out. And over here is her left fallopian tube with the dye coming out. And you can just kind of imagine there's an ovary kind of sitting right here, and there's an ovary kind of sitting right here. So this is the patient's actual X-ray. Then we did the water ultrasound. So this is her uterus right here. And then this is the lining of the uterus. It's nice and smooth. This black right here is fluid that I've inserted into her cavity. And I'm checking for growth. So I'm looking for little polyps. So polyps in the uterus are going to look like this. They're going to be these little bumps, these little kind of growths or projections into the uterus. And she's clean for those. So check that off the list. She doesn't have that. So pandemic, we did a Doxy Telehealth Consult with them, and I reviewed all of her testing. So her water ultrasound was good. Her tubes were good. Her AMH was good. She has plenty of eggs, but it wasn't consistent with PCOS. Her hemoglobin was a little low. So we have her taking iron. Vitamin D is a little low. So we have her taking some vitamin D. And then she was taking this agestin, which is the synthetic progestin, the norethindrome. Her spotting had stopped. We did the telehealth because she had COVID. That was why. And then as soon as she was cleared from COVID, I said, all right, well, his sperm looks good. Your tubes look good. Let's try you on a fertility medicine. Okay. So as soon as you get that clearance that, your symptoms of COVID, we don't have that anymore because we do not want you to have COVID in our office. So the plan was we're going to start her on Femara, which is the Letrozole. Okay. And we provide it in 5 milligrams. So it's 2 tablets, and we take it from cycle day CD 3 through 7. And then we're going to bring her back and monitor with ultrasound on the 12th day of her cycle. And then I'm going to give her a shot of a medicine called HCG, and HCG and LH are the same thing. They help the ovary ovulate. And then we're going to tell her to have sex because her husband looks great. Then we're going to check a progesterone level, which stands for MLP, so mid-luteal progesterone. And then we're going to check a pregnancy test. We'll try this twice. And if that doesn't work, then we're going to add an IUI. We'll take his sperm, we'll wash it, and we'll put it directly into her uterus. So that's the plan we made on this telehealth consult once she gets over COVID. So COVID test negative, no more symptoms, so we can go back in the office. So the treatment plan, so this is her baseline ultrasound, and it's begin the Letrozole. So this is her uterus here. That's the uterus. This is the uterine lining. It's nice and thin. Here are her ovaries. They look a little bit more PCO now. They're going to change in appearance every time you do an ultrasound. But this ovary right here in the bottom looks a little PCO. I probably can count over 10 follicles on that. So her baseline is good. All of her follicles are less than 10 millimeters. So it's okay to start the drug. So we give her the 2 prescriptions. We give her the prescription for the Letrozole. We give her the prescription for the HCG. Okay. So we brought her back on day 11. Okay. Her lining is starting to thicken up. Okay. Follicles in the ovaries are starting to get a little plumper. Okay, we're still not super big, but you can see something is definitely growing between day 3 of her cycle and day 11. So again, our office, we're reproductive endocrinologists. Again, we can't function without ultrasound. Okay, we love ultrasound. So we told her to come back in a couple of days. So she came back in 4 days on cycle day 15, and voila, we finally have a follicle. So here is a nice mature follicle on her ovary. Her lining is nice and thick. Looks like the hormones that her body's producing is making a nice bed for the baby. Do you treat men with sperm issues? Oh yeah, no, 40% of my business is male fertility. So yeah, we have 40% of, we treat male fertility all the time. But we do the treatment for it. So we do the treatment, we do the inseminations, and we do IVF mainly for male fertility. We do have a male urology also has a specialty in fertility. It's a newer specialty, but it's a subset of the urologist. So you train as a urologist and then you do a fertility fellowship. So that's also something, and they specialize in repairing varicocele in guys. They specialize in vasectomy reversals, hormonal therapy for guys to try and get their sperm back. So, and all that, there is a subspecialty of that, but we do the actual treatment. If the guy has the problem, we do the treatment with the wife to get them pregnant. So here is the nice mature follicle. So she's a mature follicle on day 15. So we're giving her this HCG injection, which is going to mimic her body's own natural LH surge. And the medicine we use is called Ovidrel. And then when you give people, boom, this Ovidrel, the ovulation should occur within 36 hours. Okay, and same thing with the onset of your body's own natural LH surge, which you can test with an ovulation kit. So the ovulation should occur within 36 hours. So this is what we consider your fertile window. So your fertile window is this 48-hour period of time, okay, because your egg can only be fertilized for 24 hours. So we basically said you need to have sex, intercourse, IC, twice at least in the next 48 hours. And so this is what we suggested that they do, because we know she has a mature egg out there. So then what we do is we check a progesterone level. So back on that little sheet, I think it's coming up in the next slide, the progesterone peaks 7 days after you ovulate, after your LH surge, or after we give you this Ovidrel shot. So we checked it. So her progesterone level, this MLP, came back at 4.5, which is pretty crappy. We want the level over 15 to have a good chance of pregnancy. So hers is kind of lousy. So we put her on progesterone vaginally, which is the compounded suppositories we use at a compounding pharmacy, and she takes 1 in the morning and 1 at night, because we really want to thicken up that bed for the baby, and make it a nice place for implantation. Because after you ovulate, the baby doesn't hit the uterus for 6 or 7 days, and that's when implantation occurs. So that's why we want to check that progesterone and booster it kind of right away. So this is what I was talking about in the chart that we saw a little bit earlier. Progesterone, this is the lining here, it wants to thicken up. So here we have the estrogen rising, the egg pops, estrogen drops, progesterone starts to peak, and it peaks again 7 days from when the egg pops out. So this is where we check our hormone level. If our hormone level is less than 15, we supplement, and it's a reflection of the quality and the strength of the ovulation. If she doesn't get pregnant in this cycle, what we do is we try to fix things on the front end of the cycle. Okay, so what that means is that we gave her 5 milligrams, gave her 2 pills of the Femara. I would increase that medicine up to 7.5 milligrams to send out really, really stronger pulses, to try to get a stronger and better ovulation, since this one looks so kind of, like I said, the follicle went, it was very weak ovulation. But it doesn't mean you don't get pregnant, okay? So 14 days from when we gave her the HCG, we checked her beta HCG level, okay? And her first hormone level, her pregnancy hormone level was 42. Her progesterone, which is a P4, had come up to 18. Her estrogen was at 74, which is a little low. So we gave her some supplements. Now, so the way we follow early pregnancy, okay, is we want the HCG levels to double every other day, okay? So we want it to go from 42, and then we want it to at least be 84. However, hers went up to 201. Her estrogen was also 201 because we slapped some estrogen patches on her, because it's not 74 is kind of a wimpy estrogen level also. And then I guess she didn't come back in 4 days. She came back 5 days later, and we're up to 1203. And so what we did with that was, now after we see definitely the levels rising, we see she's got good progesterone supporting the pregnancy, good estrogen supporting the pregnancy. Now we schedule her for ultrasound. And so this is what we saw. So on our first ultrasound, this is the uterus, this is her little yolk sac. Okay, that's the first thing that forms. And this little thing right here is the baby. Okay, and the baby's only around 4 or 5 millimeters when you're 6 weeks pregnant. And this is her ovary. Okay, so she obviously ovulated from her left ovary, and this is that corpus luteum cyst. This is the cyst that after the egg pops and it fills with blood. So this ovary is what's making progesterone, what's making some of the estrogen, even though again we're supporting it with extra patches and extra vaginal pills just because we're fertility specialists and we love hormones. So she came back and the baby had grown. So this is the baby at around 8 weeks pregnant. And this is the baby's heartbeat right now. The baby's heartbeat's going at 165 beats per minute. So this is like just super exciting. So this is kind of a summary here of her OB scan. So she came with her partner and she got pregnant on the first femara cycle with intercourse. Her progesterone level was 4.5. And then we increased it. It increased to 18.5 when she had the positive beta. I think she might have come in and come bleeding. I think she went to the emergency room and was bleeding. That's why we saw her on this day. So the ultrasound that we just showed you was 8 weeks, 4 days. Her due date is actually September 11th, 2021. Her crown rump, fetal pole and the crown rump length, they're equal. She has a heart rate of 165. She's got a big CL, corpus luteal cyst. So she's still taking the metformin. So I read of the Riot Act about keeping her blood sugars controlled because blood sugar elevation and diabetes in early pregnancy will cause miscarriage. So she had checking her blood sugars 4 times a day, checking her fasting blood sugars. We went at less than 100 and we went at 3 more times postprandial. So we do a 2-hour postprandial, checking her blood sugar. Hopefully we went at less than 140. Again, she's taking these viral patches. She's taking progesterone. We have stopped those at 12 weeks. Once we know the placenta is on autopilot, and she's taking her prenatal vitamins. And at 8 weeks, that's when in our office, we send them on their merry way to OB. So we get them pregnant. We check the early blood levels. We do 1 ultrasound at 6 weeks. We do another ultrasound at 8 weeks. And then off they go. She actually just DM'd me on Instagram 2 weeks ago, I think it was, and she sent me a picture of the baby, the baby's 15 weeks now. So it was a cute little picture of the baby. I'll probably post it at some point. So anyway, this is like the funnest job in the world. Okay. So let's see. Do you recommend particular stress management strategies to increase chances of pregnancy? Stress management is huge. Yeah. Stress management is really huge. Because lots of people, they're not getting pregnant because they think there's something wrong. And 50% of my day is cycle. Okay. Because the fear of the unknown, the fear of not knowing if you're ovulating, fear of not knowing if your sperm are good. So sometimes what we'll do is we'll do the workup. We'll check the tubes. We'll check the sperm. We'll check for ovulation. And you tell people everything's fine. They go home and get pregnant. They don't even need me. So stress can be a huge issue. Do you ever have patients who struggle to keep with the instructions, like keeping up with meds? Okay. We write things down in our office, like we have checklists, okay? We try to like break this down to like a 3rd grade level because not everybody, eats, sleeps, and drinks fertility. And so what I try to do with my patients is just like I've tried to do with you guys today is break it down and try to explain it where you can understand it, okay? So not just say, here, take these pills and have sex. So I try to break it down for the patient. This is why we're giving you the pill. This is how this pill works. This is what we're trying to accomplish. So I do it. And then I have medical assistants that have a checklist. Take this pill on this day to this day. Come in on this day. We'll walk you through the process. So again, we walk all of our patients kind of through the process, and still some of them still screw it up. But we do try and we make, for our high-tech treatments, like we make them calendars, say, do this on this day, do this on this day, do this on this day. And all they have to do is look at the calendar and it should be pretty obvious what to do, but it is a very kind of complex thing. But I think more teaching the patient what the goal of what we're recommending is and why we're recommending it, really helps. Even my own sister, who I helped my niece get pregnant with IVF, my sister said to me, she said, well, why does Katie have to take, estrogen and progesterone? Doesn't her body just know she's pregnant? I'm like, no, it doesn't. It's a frozen transfer. Like your ovaries aren't working because your ovaries make these hormones. So my sister's a nurse, so she didn't even understand why she's taking this estrogen and progesterone stuff. And so your placenta takes over, which is why I have this patient on estrogen patches and estrogen and progesterone capsules because her ovary wasn't doing the job. She needed a little extra support. So we try to really, again, education of the patient, I think, is the most important for not screwing up your treatment. What's your opinion on acupuncture? I love acupuncture. I have so many acupuncturists, on my speed dial that, I treat acupuncture as an adjuvant to everything that we do. I think it can even get people to ovulate with PCOS without taking fertility medicine. I mean, I've had some patients who want to be very holistic, and I said, well, go to the acupuncturist and have her, use the needles and get your ovary to work. And I've had it happen. Dietary changes are really big too, as far as PCOS patients and getting your ovary to work a little better. But I'm very pro acupuncture. Do these hormone treatments make people feel sick? You know what? Clomid, okay, which has been used since the 1960s, has a 10% side effect profile. So it doesn't really make people feel sick. It makes them feel weird in 10% of the times. Like some people just feel angry. They feel on edge. People say they didn't feel like themselves. Sometimes it can cause ocular problems like blurry vision changes. Sometimes it can cause headache. Definitely causes hot flashes. So 10% of people on Clomid don't like it very much. Letrozole, because it's an aromatase inhibitor and it doesn't block all the estrogen receptors in the body. Letrozole doesn't have those side effects. So some people do feel weird on the fertility treatment, but it's not the majority of them. A couple of participants of you asked who's behind. Oh, okay, that's Jacob. Okay, Jacob is a fourth-year medical student at Nova. Okay, he'll be graduating. He's got this rotation left, and he's got one more rotation left, and then he's graduating. So he's just listening because he's my student and he's learning too. What causes miscarriage? The most common cause of miscarriage is aneuploidy. Okay, so what aneuploidy is extra chromosomes in the embryo. Okay, so it's just a fluke of nature. It's just bad luck. Okay, if patients are having multiple miscarriages, I have a whole lecture on recurrent miscarriage, and there's a whole bunch of things we work them up for, but usually not after the first miscarriage. But most miscarriages are caused by just a bad luck, bad chromosome, an extra one stuck in there. What issues have you seen with Hashimoto's, thyroiditis, and oliva? Okay, so that's a cool question. Again, that's a very highly intelligent question. So Hashimoto's thyroiditis, okay, means that you have antibodies attacking your thyroid. Interestingly, okay, in our practice, we believe in immunologic infertility. And because you have antibodies to your thyroid, you also could have antibodies against pregnancy. So I do find maybe 60% of my patients who have Hashimoto's also have thyroid, also have what we call elevations in their killer cells, and their killer cells can actually attack a pregnancy. And so they do go hand in hand. So we are very aggressive at working up patients, making sure that they don't have these elevations in their killer cells or any type of something called antithyroid, antiphospholipid antibodies, which we do see commonly. And it's just because people with antibodies against something, okay, have a tendency to have antibodies against other things too. Not all of them, but there's definitely a higher percentage than if you didn't have the thyroid antibodies. Have you heard about endocrine disruptors and their effect on male sperm? Absolutely. Yes, I do. Yes, so endocrine disrupting chemicals, okay? So I've got gobs of fascinating cases about different chemicals affecting guys' sperm. It's really crazy. Plastics. I just had a guy who was chewing on plastic water bottle caps. And remember I told you earlier that 4% of your sperm need to have a normal head, neck, and tail? This guy had semen analysis after semen analysis with 0% normal forms of the sperm. It took me, I don't know, at least 8 or 9 months after repeating semen analysis to put him on vitamins, changing his diet, doing all sorts of stuff to figure out it was the plastics that the guy was chewing on that were messing up the shape of his sperm. So there's tons of endocrine disrupting chemicals out there, plastics being a big one, especially because there's estrogen that leaks into plastics and can actually affect sperm count. Not everybody, just a susceptible individual, but yeah, we do look at that when we see abnormalities in guys' sperm. What does hyperpigmentation? So hyperpigmentation indicates, actually not really, on the black people's skin, black skin, the hyperpigmentation is even darker. Like it's a much darker area, and definitely on the back of the neck. You can see it in black people and on the inner thighs, but it indicates elevations in insulin levels. Okay, that's one of the things that's if you see that, you draw an insulin level where the insulin level, I don't like the top normal insulin to be higher than 14. I'll see insulin levels of 50, 60, and 70 in patients with hyperpigmented areas on their body, but you can see it in black people. And so I think we got the question. Is OMM a useful skill to know in your practice? Well, I mean, I love OMM. It's something that is great for gynecology. Definitely helps. There's techniques they can use for menstrual cramps. I don't use it as much in reproductive endocrine. I think it works great for back pain. I mean, I adjust my boyfriend's back all the time, just because I know how to do it. I think it's an important skill for any doctor to know, especially family members who keep throwing out their backs, or anything like that. I think it's a great skill. I don't use it a lot, but I think I've had several patients who I've actually, just because of the complaints they have, I've sent them to osteopathic physicians, even before they were going to have like some sort of spinal surgery, and the osteopath fixed them. They didn't need surgery anymore. So, I mean, I think it's just a great skill in general, to know, especially for any type of family practitioner, sports medicine doctors, anything. I think it's really cool. Oh yeah, we do tons and tons of that. So I could answer that question. We do tons and tons and tons of reciprocal IVF. Like it's really, really a very popular thing. Where there's my thing here. I just hold on here. Where's my reciprocal IVF? Oh, have you worked? Yeah. So, oh my gosh, we see same-sex females couples all the time. And so what reciprocal IVF is basically we're gonna harvest the eggs. I've probably got three or four couples right now that we're doing it with. I harvest the eggs from one of the female partners, and usually it's the most fertile. So we kind of, if one wants to be pregnant and the other doesn't want to be pregnant, we'll kind of do it that way. But I usually prefer to use the eggs from the one who's more fertile and put them in the one that's less fertile. I've got one now that actually both the couples, Tiffany and what's her partner's name? They both went through. Tiffany has one embryo, and her partner has like 7 normal embryos. I think we're gonna use the one partner and the other partner, but yeah, we do reciprocal a lot. We're actually even doing, we've done a couple cases. I did one last year, same-sex males. So same-sex male couple, we used both of the we used the sperm of both guys, and we fertilized donor eggs with one guy's sperm and the other guy's sperm, and then we put an embryo of the one gentleman into the surrogate, and an embryo of the other gentleman to surrogate, and the surrogate carried twins, basically one baby for each of them. So we do same-sex male couples, we do same-sex female couples. Yeah, it's pretty common in our world. We want to work with them. Yeah, just REIs, most REIs are doing it. So I think hopefully I answered that question. Your patients ever struggled to keep up the structure? I did that one. It's just, I think I'm just gonna roll down to the bottom here. If you have patients with thyroid ablations for Graves' disease, have decreased fertility. I have not. Most of my patients who've had thyroid ablations, the I-131, it has not messed with their fertility. We've successfully gotten them pregnant after they've been cleared in about a year from the I-131. Hashimoto's also called. Yeah, it can. I've had guys that if their thyroid hormones were not corrected, if they were off, I had a guy he was off his thyroid medicine, sperm count tanked, because it all has to do with the pituitary production, also sending these hormones out to your testicles to make them work. So if they have a thyroid that's irregular, I have a guy right now, actually, he's got a TSH that's super duper high. He lives on Key West, and we're sending him to a thyroid specialist to get that fixed because his sperm count is super low. So yes, it can affect male fertility as well. If a trans woman takes estrogen, can impact your ability to produce viable sperm. Yes, which is why we do freezing. So before anybody transitions with hormones, what we do is we bank their sperm. So, before anybody goes on hormones, whether it's, we'll have girls who are going to, change gender to a male, and they're going to start testosterone. We harvest their eggs before they even start any of the testosterone, because yes, it could absolutely affect their organs. And when we have, we recently had a guy who was going to start all the hormones, the estrogen hormones. And, we said, bank 4, 5, 6 vials of sperm, because yes, the estrogen absolutely will affect sperm production. So before you start hormones, just bank your sperm. We recommend that 1,000%. So hopefully I got to all the questions. I know I talked fast, but I think I got everything. And then I think I got one more slide here. Yeah, so this is again for our future physicians advice. Okay, so never give up on a dream just because it takes time to accomplish it. It's, I love medicine. Again, I was debating back and forth whether I even wanted to be a doctor. And as soon as I kind of got into it, I'm thinking this was the best thing I ever did. And one of other best things I ever did was do a reproductive endocrine fellowship, because again, my job is like ridiculously fun. I love it. So everybody, thank you everybody for attending. You guys can follow me. I'm on Instagram. I'm like my new TikTok fame. I've actually made Jacob. Okay, Jacob is now a new TikTok star. His video with me, his first one. He has 800,000 views. Okay, like 800,000. My one with Jacob. I'm also on Facebook at Dr. Ellen Wood. You guys can email me if you have questions. That's my office number. If anybody is interested in in-person shadowing opportunities, we do have students in our office. We're one of the nice practices that we have a big enough space that we can social distance everywhere. A lot of practices, again, is why you're doing this. Guys don't let you in to shadow. And that's again my email and our office number. Hopefully everybody enjoyed the presentation. And again, check out Jacob's video on my TikTok. And hopefully I answered all your questions. All righty, how we do? Did we do in time? I think I got the time down this time. Yeah, 2:30, right, exactly.
Thank you so much, Dr. Wood, for another detailed and interesting presentation. We love the case and how much work you put into it. And a bunch of the participants also agreed they love having the photo of the patient. So thank you so much. It was an honor.
I just think it makes it more like, because this is, I mean, and again, she's going to deliver in September. I mean, and again, I think it just makes it more real, like when you're, you know, to follow through with a real case, because you'd be doing that if you're in the office, you know.
Thank you. Everyone, make sure you check out her socials to learn more from her. Her Instagram is at Dr. Ellen Wood. Additionally, the link will now be posted in the chat, so please fill it out within 30 minutes, and it'll also be in the description of the video.